Hi, my name is Dr. Jenny Yu, and I'm a postdoctoral research fellow at Boston Children's Hospital and a general surgery resident at Beth Israel Deaconess Medical Center. This video is just one in a series of subjects brought to you by Channel 1 On-Demand Nutrition Education. Today, we will discuss the incidence and development of cholestasis in surgical neonates receiving a soy, MCT, olive, and fish oil-based intravenous lipid emulsion. While life-saving for the over 4,000 children a year who are dependent on it due to intestinal failure-related syndromes, long-term parenteral nutrition use may lead to intestinal failure-associated liver disease, or IFALD, which may ultimately require liver, intestinal, or multivisceral transplantation. IFALD affects up to 85% of neonates and 27% of children who are dependent on PN. And surgical neonates are at particularly high risk. Other risk factors for developing IFALD include infection or sepsis and prematurity or low birth weight. Historically, the only FDA-approved initial intravenous lipid emulsion, or ILE, in children was soy oil-based ILE. However, soy ILE contains a high concentration of pro-inflammatory omega-6 fatty acids and hepatotoxic phytosterols, which may contribute to the pathogenesis and exacerbation of IFALD. Fish oil-based ILE contains a high concentration of anti-inflammatory omega-3 fatty acids and is approved in the United States as a salvage strategy for IFALD in children, but not for prevention or for use as an initial lipid source in PN-dependent infants. Meanwhile, a soy, MCT, olive, and fish oil-based ILE has gained traction in recent years for off-label use as a potential hepatoprotective ILE and has, in the past year, become the first 4-oil ILE to be approved for use as an initial lipid source in infants and children on PN. To review, this 4-oil ILE is composed of soybean oil, medium-chain triglycerides, or MCT, olive oil, and fish oil. Components of various lipid sources are identified in this table. Factors to consider in determining the optimal ILE in patients include that anti-inflammatory omega-3 fatty acids and alpha tocopherols are high in fish oil. Hepatotoxic phytosterols and pro-inflammatory omega-6 fatty acids are higher in soybean oil. And that soybean oil and olive oil, both components of the 4-oil ILE, contain a significant phytosterol concentration compared to fish oil. In patients requiring PN for greater than 14 days, the standard practice dosing at our institution of soy ILE is 1 gram per kilogram per day, and for 4-oil ILE is 3 grams per kilogram per day. Prior studies have demonstrated that lower doses of 4-oil ILE may increase the risk of essential fatty acid deficiency, hence the higher standard dosing compared to soy ILE. At these standard doses, the amount of soybean oil in the lipid emulsion is similar between soy ILE and 4-oil ILE. However, due to the higher concentration of phytosterols in both soybean and olive oil, the hepatotoxic phytosterol load in the 4-oil ILE may be higher than that in soy ILE at standard dosing. Preclinical studies investigating 4-oil ILE have demonstrated that it may prevent and reduce cholestasis, total bilirubin, CRP, and omega-6 fatty acid levels compared to soy ILE administration in the same preterm piglet model of IFALD. However, clinical studies demonstrate that patients on 4-oil ILE may still develop IFALD, and the data comparing 4-oil ILE to historically standard of care soy ILE therapy analyzes a heterogeneous population with inconsistent results. As such, the purpose of the study was to assess the incidence of cholestasis in gastrointestinal surgical neonates requiring PN and receiving 4-oil ILE in order to determine whether it may serve as a hepatoprotective intravenous lipid emulsion. This was a retrospective review at a single tertiary care children's hospital. The study group was neonates on 4-oil ILE for 14 or more consecutive days, and a control group was used for analysis who received soy ILE for 14 or more consecutive days. Patients who received PN and lipid at an outside institution were excluded if their dosing administration could not be verified or received a different lipid emulsion for more than 7 days. Other exclusion criteria included confounding comorbidities, including intrinsic diseases of the liver, heart failure and congenital heart defects, multisystem organ failure, cystic fibrosis, and medical necrotizing enterocolitis not requiring surgery. 180 patients were identified as surgical neonates who initiated PN within 30 days of life and required support for greater than or equal to 14 days. Exclusions resulted in a final cohort of 152 patients, including 39 patients who had varying days of prior lipids or without lipids for up to 7 days. Of note, the included patients still had ILE support with either 4-oil ILE or soy ILE for greater than or equal to 14 consecutive days. The initial cohort of 152 patients was further refined into 2 additional cohorts with more stringent exclusion criteria. Cohort 2 excluded patients who received a different lipid for 1 to 7 days and patients who had a disruption in lipid administration for greater than or equal to 7 days. Cohort 3 included only patients who had no prior lipids before initiating the 14 consecutive days of either 4-oil ILE or soy ILE, and patients who did not have any disruptions in their treatment. We also identified 2 additional cohorts of 1-to-1 or 1-to-2 paired matches of 4-oil ILE to soy ILE patients. To match, differences in group balance were reconciled by requiring exact matching of baseline direct bilirubin and number of available direct bilirubin measurements over time, while minimizing differences in total phytosterols within each pair. Additional characteristics considered in matching included postmenstrual age, baseline weight, total days follow-up, percent of calories due to PN, and diagnosis, but none of these were obtained in the model for adjustment as they did not significantly influence the results. Daily data was collected for anthropometric measures, nutritional intake, laboratory data, including direct bilirubin, triene to tetraene or T to T ratio as a measure of essential fatty acid deficiency, alanine aminotransferase or ALT as a marker of liver inflammation, and triglycerides. Total PN administered was also noted, and the percent calories from PN and total phytosterol load were calculated based on the total calories and PN composition. The primary outcome in this study was incidence of cholestasis, used as a marker of IFALD and defined as a direct bilirubin greater than or equal to 2 milligrams per deciliter. Data collection continued for a 9-week observation period, or earlier if cholestasis resolved or the patient was weaned off of PN. The secondary outcomes were latency to cholestasis, growth, essential fatty acid deficiency defined as a T-T ratio over 0.2, liver inflammation as measured by ALT, and dyslipidemia as measured by triglycerides. Overall, in the entire cohort, or cohort 1, 63% of patients receiving 4-oil ILE developed cholestasis after at least 14 days of therapy, while 22% of patients receiving soy ILE developed cholestasis after the same period. When adjusting for the baseline direct bilirubin and number of available bilirubin measurements, the incidence of cholestasis in the 4-oil ILE group remains significantly higher. In each of the cohorts with more stringent exclusion criteria, patients who received 4-oil ILE consistently had higher incidence of cholestasis compared to those who received soy ILE, including after adjustments for baseline direct bilirubin and number of bilirubin measurements. This included the matched cohorts, which demonstrated significantly higher incidence of cholestasis in the 4-oil ILE group, 78%, compared to the soy ILE group, 17 to 22%. Time from lipid day 1 until cholestasis was evaluated by Kaplan-Meier product limit estimation. The latency to developing cholestasis was significantly shorter in the 4-oil ILE group than in the soy ILE group in all cohorts. Weight for age Z-score was overall higher in patients receiving 4-oil ILE compared to soy ILE, but did not reach statistical significance. Similarly, length and head circumference for age z-scores were also slightly higher in 4-oil ILE patients compared to soy ILE patients, although again, these data did not reach statistical significance. T to T ratios were comparable in patients receiving 4-oil ILE versus soy ILE across all cohorts. No patients in the study developed essential fatty acid deficiency based on the limited fatty acid profiles that were available within this data collection. 4-oil ILE administration correlated with significantly higher alanine aminotransferase, or ALT, compared to soy ILE administration, indicating a potentially higher degree of liver inflammation. Patients administered 4-oil ILE also had higher triglycerides compared to those receiving soy ILE, which was statistically significant in cohort 3 and in the matched cohorts. The study determined that 4-oil ILE administration in the neonatal gastrointestinal surgical population does not reduce the incidence of IFALT compared to soy ILE administration. In fact, the incidence of cholestasis was higher, and furthermore, the latency to cholestasis was shorter in the cohort of patients on 4-oil ILE. 4-oil ILE patients also had higher ALT and triglycerides, potentially signifying some higher degree of liver dysfunction. Meanwhile, while 4-oil ILE administration was associated with slightly higher weight, length, and head circumference for age z-scores compared to soy ILE administration, these values did not reach statistical significance, indicating that the improved growth observed with 4-oil ILE administration may not justify its use when balanced with the higher incidence of cholestasis. Finally, because the standard practice dosing at our institution of 3 grams per kilogram per day of 4-oil ILE is required to prevent essential fatty acid deficiency compared to 1 gram per kilogram per day of soy ILE, after adjusting for the number of days on PN, the total load of potentially hepatotoxic phytosterols administered in 4-oil ILE patients was actually higher than that in soy ILE patients. And this is because of the phytosterol content in not only the soybean oil component of 4-oil ILE, but also the olive oil component. Nevertheless, this study carries significant implications for the care of surgical neonates requiring PN, who are a high-risk population for developing intestinal failure-associated liver disease. Mixed oil lipid emulsions may not be hepatoprotective, particularly in this population. Therefore, regardless of the lipid emulsion administered, the GI surgical neonate population requiring prolonged parenteral nutrition should be closely monitored for the development of IFALT, and further research to develop novel, truly hepatoprotective lipid emulsions for first-line preventative use in this population is imperative to improve clinical outcomes. Thanks goes to our sponsors for supporting this work, and I invite you to watch for upcoming Channel 1 videos on nutrition to learn more. Thank you.